Hi everyone, my name is Nerilyn Bisario. Today I'm presenting on bridging language gaps in home health physical therapy, especially when working with Spanish speaking patients with limited English proficiency or LEP. In home health, communication isn't just a soft skill, it's part of a patient's safety. When we don't share a language, the risk isn't just an awkward visit, the risk is that the patient may not fully understand safe transfers, device use, precautions, or the home exercise program. And those misunderstandings can lead to false, poor carryover, and worse outcomes. And I want to add a quick personal note here. I do not speak fluent Spanish. I'm fluent in Filipino and in English. That's exactly why this topic is important to me. Because when a language gap, we can't rely on guessing or getting by. We need a consistent, safe workflow that supports both the patient and the clinician. This arc from EN to ES represents that gap, that is English to Spanish. The goal of this presentation is to bridge it with a repeatable system, not improvisation. In the next few slides, I'll cover why language access matters in home health PT, what the evidence supports, three practical strategies, professional interpreters, teach back, and system level planning, and then the toolkit and workflow that puts it all together. Let's start with a realistic scenario. You arrive for a home visit after a fall. You need to teach safe transfers and possibly update a home exercise program, but you and the patient don't share language. In home health, misunderstandings show up fast because we're not in controlled clinic environment. The patient is going to practice what we taught them between visits, opened with limited supervision, and that's where risk increases. Language access matters for four big reasons. First, safety. If precautions or instructions are unclear, risks go up on safe transfers, incorrect device used, missed warning signs, and falls. Second is HEP adherence. Patients have to understand dosage as such sets, reps, frequency, and pain rules. If that's not understood, the program falls apart and progress is slow. Third is equity and patient experience. Uh, Language discordance can weaken trust and rapport. Patient may feel less engaged or less confident, and disparities in um, outcomes can widen. Fourth, clinician efficiency. If we improvise every time, we spend more time repeating, correcting, and reteaching. A consistent approach saves time long term and improves quality. So, the key message here is communication is part of intervention, not add on. This slide summarizes what tends to happen when language breaks down and what actually works. When language access fails, common problem includes inaccurate history taking, higher risk transfers and device teaching, and home program instruction getting lost between visits. Even the therapeutic alliance can weaken if the patient doesn't feel understood. The bottom line is simple. Language access is a patient safety and quality intervention. What works best is a combination of three approaches. And that will be the professional interpreters, which can improve clarity and reduce errors compared to ad hoc interpreting. teach back, which confirms understanding by having the patient explain or demonstrate, not just say yes. System level planning, meaning workflows, training, translated materials, and documentation that make language access consistent. So we're not relying on one tool, we're using a system. Strategy one is to make professional interpreter use the default, especially for safety critical teaching. So here's the workflow. Identify LEP needs early and choose the best modality. That will be phone, video, or in person. Pre-brief, share the visit goals and safety critical topics so that interpreters understand what matters most. Delivery, speak in short segments using plain language. Speak directly to the patient, not the interpreter. Confirm, use teachback and demonstration to confirm understanding. Document, record interpreter use and the key education provided. A critical boundary here is avoid ad hoc interpreting for safety critical education. Family members can help with comfort and context, but they shouldn't replace trained interpreters for complex mobility training, precautions, or risk related education. Interpreters improve accuracy, but accuracy alone doesn't guarantee understanding. That's why strategy matters. Uh, Teachback is how we verify that the education actually landed. Teachback is not a test of the patient, it's a test of whether we explain it clearly. The cycle is explain, ask, listen, reteach. Respectful script I can use is I want to make sure I explained it clearly. Can you show me how you will? And of course, there's a Spanish version of that. Me puedo enseñar cómo va? Teachback works especially where in home health PT for safe transfers and gait and sequencing. Assistive device set up like a walker or cane, HEP dosage and pain rules and caregiver assistance and techniques. A practical tip is chunk and check. Teach only 2 or 3 points, confirm understanding, and then move on. That prevents overload and improves carryover. Now, to make this consistent across visits, across staff, we need system level support. This slide is about sustainability. We can't rely on individual clinicians to remember everything every time. A system makes the right thing the easy thing. A system level plan includes first assessing LEP needs, consistently preferred language interpreter need, and how the patient best communicates. Second, on interpreter workflow, clear steps for scheduling and selecting phone versus video in person interpreting. Third, translated material, consistent handouts reduce variability and improve carryover between visits. Fourth, training and reinforcement. Staff need training on interpreter etiquette and teach back, then reinforce through quick check-ins or audits. The key takeaway is documentation and monitoring help adoption stick, and they support quality improvement. So, this is the practical toolkit, the language access bundle. It's designed to fit a real home health workflow without adding a lot of burden. The bundle includes bilingual safety handouts that's focused on prevention, device safety, and precaution. Bilingual HEP handouts designed to be low literacy friendly with clear dosage cues and visuals. A teach back checklist, which gives prompts plus a simple documentation line. Spanish PT praise cards, which supports report and basic cues, but it's not a substitute for interpreters. The goal is consistency. Patients receive clear visual and simple language, and clinicians have standardized structure. This reduces variability and improves carryover between visits. This slides is the before, during, after workflow that puts the bundle into action. So before the visit, confirm the patient preferred language and LEP needs. Schedule the interpreter based on the visit goals. Select 2 to 3 safety critical teaching points because we can't overload patients. Bring the bilingual handouts and teach back prompt. So during visit, introduce the interpreter and speak directly to the patient. Use short segments and plain language. Demonstrate transfers, device used, and HEP. Then use the teach back. Have the patient show or explain the steps. Now, after the visit, leave materials and highlights 2 to 3 key points, document interpreter used, and education delivered. Record teach back result, whether the patient passed or needs reinforcement. Plan follow up and caregiver support as needed. The point is to make language access a habit, repeatable, efficient, and safe. This slide is a practical prompt that you can use immediately. It supports consistent teach back without having to invent wording during a busy visit. A prompts focus on real home health tasks like transfers, devices, HEP, and safety rules. Let's say, for example, I might say, just to make sure I explain it clearly, can you show me how you will stand up safely using the walker or an HEP? Can you show me how many repetition you will do and when you will stop due to pain? So the key method, we ask the patient to demonstrate or explain back, not just say yes. This makes education measurable and improves carryover. So this slide summarizes what to start doing right away and what to avoid. Use professional interpreters for safety critical teaching. Speak in short, plain language segments. Use teach back for transfers, devices, and HEP. Leave bilingual materials and highlight 2 to 3 key points. Document interpreter used and teach back results. And the don't rely on family interpret complex mobility education. Don't ask only do you understand, because yes and no isn't a confirmation. Don't teach everything at once without checks. Don't assume nodding equals comprehension. Don't skip the workflow because it feels slow. So teaching later costs more time and increased risk. A simple question step is to start one habit, document teach back results on every LEP visit. once the routine expand to the full bundle. Okay. And this references support the strategies in this presentation. Professional interpreter, teach back as a safety method, and system language access planning. Um, Language should never be the reason a patient receives lower quality care. Language access is equity, it's professionalism, and patient safety. When we standardize interpreter use, teach back, and clear bilingual materials, we deliver consistent care no matter what language patients speak. That is a standard our patients deserve. Thank you so much for listening.